Hello, everyone, and thank you for joining us this evening for the seventh week of the RISE Institute in Rugby Research and Injury Prevention Group 2026 Summer Lecture Series. So tonight, our featured speaker is Dr. Lasun Oladeji, who's an orthopedic sports medicine surgeon and assistant professor of orthopedic surgery at the University of Miami Leonard Miller School of Medicine, and also assistant professor of orthopedic surgery.
So the talk that I wanted to give today, when the ACL isn't enough, other considerations in ACL reconstruction. And I was hoping just to give a broad overview of some of the research that's been done and the things that we as surgeons are thinking about doing in an attempt to make outcomes following ACL reconstruction better. So as an outline for this talk, I'll start by giving some background about the ACL and reasons for performing ACL reconstructions. Then I'll talk about the challenge with ACL reconstruction, which is despite the fact that we do our best to do a really good surgery, sometimes patients don't have the best outcome. And, you know, in order to prevent this, we are trying to look at various techniques that we can use to improve ACL reconstructions. I'm going to try not to get too far in the weeds, but hopefully just give a little bit of a background so that when you guys hear certain terms, you're familiar with them. So first, the anterior cruciate ligament, or the ACL, it's a band of really strong connective tissue in the middle of the knee. It's one of the two main ligaments, with the PCL being the other main ligament. The ACL is approximately 32 millimeters long and between 7 to 12 millimeters wide, and it has two bundles that work together to serve distinct purposes. The anterior medial bundle is tight in flexion, and the posterior lateral bundle is tight in extension. Together, when both of these bundles are working appropriately, the ACL protects and prevents the knee from experiencing anterior translation of the tibia and internal rotation of the tibia. And the two ligaments, both bundles are needed in order to prevent against this. Um, Unfortunately, ACL injuries are very common, and most of your favorite athletes, you may have heard of someone tearing their ACL, whether it's Kyrie or Clay or any other professional athlete. They account for approximately 50% of knee injuries. And in the United States every year, somewhere in the neighborhood of 300,000 ACL reconstructions are performed. Um, this is pretty significant because we spend approximately $1 million in healthcare expenses on ACL reconstructions. And ACL injuries are significant because they can increase the rates of arthritis. And it also takes somewhere in the neighborhood of 9 months to over a year for an athlete to recover. So depending on where you are in your life cycle as an athlete, an ACL injury could potentially, put you in a position where it's very hard to continue your career, or you don't continue it in the same manner. So that's why these injuries are pretty important. So who is most likely to experience an ACL tear? Typically, it's our younger athletes who play sports that involve pivoting, cutting, or jumping. The vast majority of ACL injuries actually happen without someone being touched. And female athletes are really high risk for experiencing ACL injuries. They're 2 to 8 times more likely to experience an ACL injury than male athletes of the same age. And specifically, if you think about female athletes who are in high school or in their early college careers, those are the athletes that really are more likely to experience these injuries. Sports that put you at risk for experiencing an ACL injury include soccer, basketball, volleyball, and football because they involve a great deal of pivoting and cutting. So why do we perform an ACL reconstruction. And there's multiple reasons, but I would say the biggest is the goal is to restore knee stability, especially in a younger person. We want young people who are active to have a stable knee. Um, Another reason is to get our athletes back to playing sports. If we do an ACL reconstruction, an athlete is 3 times more likely to return to sports than they would if they didn't have an ACL reconstruction. And this number increases even more if you specifically look at sports that have cutting and pivoting. It may be easier for someone who plays golf or even skis to do so without an ACL than it would be a football player or a soccer player. Further, there are decreased rates of future knee injuries in patients who get an ACL reconstruction. This graph on the right attempts to show the rates of re-injury to the meniscus and cartilage if you undergo non-operative treatment, which is that yellow line. And then delayed reconstruction would be the green line. We see that there's a lower incidence of these injuries. And if we do early reconstruction, which is the blue line, the rate of these injuries decreases even more. And you compare that to the control group, which is the group that has not experienced any injury. And, obviously, if you don't have a knee injury or ACL injury, you're less likely to experience these sorts of injuries. But then the earlier we're able to do the ACL reconstruction, the better we're able to preserve the health of your knee overall. So another reason to perform ACL reconstructions is to decrease the rate of arthritis and decrease the rate of people who get total knee replacements. And similar to what we saw in the last graph, if we treat an ACL injury without surgery, there's both a higher rate of arthritis and also a higher rate of number of people who get total knee replacements. And the earlier that we're able to intervene and do surgery, the less likely someone is to need a total knee replacement or to get arthritis. And the easiest way that I like to think about this is the ACL's job is to provide stability to the knee. And when we no longer have an ACL, your knee is now moving backwards and forwards a little bit more. And the cartilage and the meniscus and all of the other structures are getting pinched and getting rubbed on. And that just leads to them wearing down a little bit quicker. Uh, when we talk about doing an ACL reconstruction, there are multiple different grafts that we can take. And the graft is just the donor tissue that we use to reconstruct the ACL. Sometimes we will take a piece of tissue from the patient. That's called an autograft. And the most common autografts that we use in this country are the BTB, which is the bone, patellar tendon bone. That's one of the most common, and that's called the gold standard because been used for so long and the outcomes are great. There is also the quad tendon right here, which comes from this area. And then there's the hamstring tendon right there. For some patients, we can make the decision to use an allograft, which is using tissue from someone who has passed away. And we do that primarily in older patients who want to enjoy sports, but aren't going to play at such a high level. So they'll put less stress and less demand on the graft. Ultimately, there are pluses and minuses of each of these graft choices that we think about as surgeons, and that influences us in when we talk to patients and when we educate them. Here, this table just attempts to highlight some of the risk of re-injury after an ACL reconstruction based on the type of graft. And I think the big thing that is important is I said the BTB is the gold standard, and that has a rate of re-injury of approximately 3%. Um, the quad tendon is one of the ACL grafts that has become really popular over the past 10 years or so. That has a similar re-rupture rate in the neighborhood of 3% as well. The hamstring graft is something that has been used historically in Europe, and it's also used on the East Coast. That has a little bit higher failure rate, but it's an easier surgery to recover from. And then allografts, they have, somewhere in the neighborhood of a 10% re-rupture rate. But the benefit is that we don't have to harvest tissue from the patient to do the surgery. So it's an easier recovery. So in some of the more mature patients, this is something that we may think about. Um, But in addition to the numbers that I showed you on the other screen, there is another group of patients who may experience clinical failure, even though technically their ACL hasn't torn. We use various scoring systems to determine that. One is called the IKDC, and that just allows us to measure a patient's performance when doing certain tests. And we would expect them to do better with an ACL reconstruction, but some patients, if their graft is a little bit looser or if it's not functioning appropriately, they may score poorly on this scoring system. Also, we can use our physical exam. So if we do a physical exam and we compare the stability of one knee to the other using tests such as the Lockman or the pivot shift, what we sometimes find is some patients, even though they've undergone an ACL reconstruction, their knee is a little bit looser. Another way to quantify this is using a device called an arthrometer, and that just gives us numbers instead of using our hands. And in patients, when there's a side-to-side difference greater than 5 millimeters, that tells us that the graft isn't working properly. Um, Overall, when we look at both failures in the terms of re-rupture and also clinical failures, what we'll find is there's a higher incidence of clinical failure. And one paper in 2013 that was published in Arthroscopy attempted to quantify that. And they found that approximately 10% of patients who underwent reconstruction ultimately failed in some way. And the truth is, depending on the graft type, this number can even increase higher. So what do we as surgeons do to decrease failure rates? Well, number one, we think about each patient. We think about their age, their desired activity level. We think about if they have a family history of ACL tears. We think about if they've torn an ACL on either the same knee or the other knee previously. And then we use this to try and come up with a plan. So roughly, assuming you do a perfect ACL surgery, the other things that we sometimes will add on is we can add a procedure to increase the strength of the ACL graft. So one thing that we do is we add suture, and this is called an internal brace. We can also do procedures that increase the rotational stability of the knee. Two such procedures are the lateral extra-articular tenodesis and the anterolateral ligament reconstruction. And then finally, in some patients, their anatomy or their bones are shaped in a way that makes them more likely to tear their ACL. And in those patients, we can do an osteotomy or we can cut the bone. So let's talk about the first. So ACL reconstruction with suture augmentation. This is just a fancy way, if you look at the picture here, this is the new ACL that has been placed in someone's knee. And running alongside the ACL, we have this blue suture. And the blue suture is essentially supposed to act like a seatbelt. If they, in the early postoperative period, they find themselves in a position where they fall or something is happening that the graft is experiencing increased load, they have this seatbelt there, which is supposed to help shield the graft from experiencing those stresses until the graft is more mature. So it's a suture that's implanted at the time of surgery. And different companies have different suture types. But one of the big companies, their name is Arthrex, and they call their product an internal brace. So biomechanically, there have been multiple studies that say that when we use suture tape along with our ACL reconstruction, ultimately the graft is stronger. So the graft is able to withstand a greater load to failure. It is less likely to stretch. And there are studies showing that typically this effect is seen when a stress of 200 newtons or more is placed on the graft. So this is just saying that when someone is living their normal life and there isn't any sort of fall or any sort of stress placed on the graft itself experiences the load, which is important because we want the graft to remodel. But if something happens and they fall or they put their knee in a position that normally might injure the graft, the suture tape is there to take some of that load. Um, and this is just the second study, which was published in Arthroscopy in 2022, showing that if we do the BTB ACL reconstruction with a suture tape, there is a 104% increase in graft stiffness and a 57% increase in load to failure. So the graft is stronger, and that's a good thing. Clinically, we also have a couple of studies that have looked at the results of ACL reconstruction with suture augmentation. The first study was published in the Orthopedic Journal of Sports Medicine, and it looked at 100 patients who had an ACL reconstruction with the internal brace compared to 100 patients who underwent the ACL reconstruction alone. And this particular study found that when you did the internal brace, there were fewer revisions, so 1% versus 8%. And when you tested the graft stiffness and the knee stability using an arthrometer, there were improvements in both groups. There was a second study that was recently published in 2024, and they looked at a cohort of 55 people who got regular ACL reconstruction versus 55 who got an ACL reconstruction with the internal brace. And they found that when looking at the different patient-reported outcome scores that we give people just to see how they're feeling, there was no difference between the two groups. But the group that had the internal brace had one re-rupture versus the group who didn't, they had four re-ruptures, and they found that this was significant. So in summary, it appears that basic science, animal, and some of the clinical studies would suggest that when you do an ACL and you add suture to it, it can help reduce the failure rates. However, like everything in medicine, we need long-term data. We need to know what happens when we keep suture in someone's knee over a course of 10 years or 20 years. And we need to make sure that this isn't something that can lead to arthritis or increased problems like that. The next group of procedures that we will kind of talk about are meant to address the rotational stability of the knee. In 1879, there was a French OBGYN named Paul Seguin, and he looked at x-rays and he described this fracture that is seen in the lower right corner of the screen. And it's called a Seguin fracture. Basically, it's an avulsion fracture at the proximal tibia as a result of forced internal rotation of the knee. What he found was, in addition to this fracture, there was a fibrous band that was attached to this piece. And, that later became associated with ACL injuries. So in clinic, when patients come in, the first thing I do is I get x-rays. And I can look at certain things on the x-ray in an attempt to determine if they have an injury. One of the things is if I see this fracture right here, it's telling me to be really concerned about the possibility of an ACL injury. And that's something that surgeons and scientists figured out in the 1980s and 1990s. Um, but that piece of tissue that is attached to that region is called the anterolateral ligament. And it runs from the lateral aspect of the femur right here, the lateral epicondyle, and it inserts on the tibia, um, on the anterior lateral tibia. So it's really taut in flexion and internal rotation. And that piece of bone, the Sagone fracture, is probably due to the ligament pulling off of the bone in that area. Um, so what we've also figured out is when we do an ACL reconstruction, one of the reasons why patients sometimes fail is that there is still some anterior lateral rotational instability. And on one of the first slides, I talked about how the role of the ACL is to stop the tibia from moving forward relative to the femur and also to help with rotation. So knowing that this fracture sometimes happen, what orthopedic surgeons have done is they've done research and they realize that if we add an extra procedure on the lateral side of the knee, we can potentially reduce the risk of re-rupture, especially in higher level athletes. So two such procedures, one is the lateral extra-articular tenodesis, and the other is the anterolateral ligament reconstruction. The lateral extra-articular tenodesis takes a strip of tissue from the patient's own knee on the outside, called the IT band, and we use that to reinforce the anterolateral aspect of the knee. The other alternative is that we can take a graft and we can essentially use the graft to reconstruct that ligament. So we put one part of the graft near the lateral epicondyle where the ligament starts, and then we put the other end of the graft on the lateral aspect of the tibia. The difference between the two procedures is the second is technically more anatomic because we're controlling where we put both ends of the ligament. The first is a little bit cheaper because we don't have to use an allograft. We can use the patient's own tissue to reconstruct that ligament. And this is just a picture outlining the two different approaches. So here on the left, we have the lateral extra-articular tenodesis. We take the IT band where it attaches, and we take a strip of tissue, and we put it under the lateral collateral ligament, which is right here, and then we attach it posterior and proximal to the lateral epicondyle, which is in this region right here. So proximal, posterior. The other set of procedures, the anterior lateral ligament reconstruction, we take a graft, and there's a couple ways we can do it, but we're just putting in tissue in the same location. So right here and around the lateral epicondyle, and then right here along the anterior lateral aspect of the tibia, whether we do it with one tail or two tails there. And this is just a surgery description showing the size of the incision that we make for a lateral extra-articular tenodesis and what it looks like when we take a strip of the IT band and how we then shuttle it under this ligament right here. And then we can attach it in the knee right there. But what does the data say? Well, one of the biggest studies was done by this guy. His name is Al Getgood. He published this in 2020. It was a study of 618 patients who were getting ACL reconstruction with a hamstring. And one group had an ACL reconstruction by itself. The other had an ACL reconstruction with the LET procedure. And he only enrolled patients who were high risk. So patients who had a pivot shift, meaning they were rotationally unstable, patients who were going to go to high risk cutting and pivoting sports, or patients who were, very flexible. They had a lot of ligamentous laxity. And the outcomes that he looked at were both graft failure, requiring a revision ACL reconstruction, and also clinical instability. So overall, he found that 45 patients experienced a graft rupture. 11% of patients in the group that had an ACL reconstruction only, and 4% of patients who had an ACL reconstruction with the LET procedure. And from this, he was able to determine that in order to prevent one patient from experiencing a graft rupture when we do an ACL reconstruction, we need to do the LET procedure on about 14 patients. And this was over the first 2 years. So this was a pretty big study for people who do ACL reconstructions. And it said we can do this one technique that only adds about 10 or 15 minutes to the case, and we can significantly make it less likely for patients to experience an ACL failure. The other procedure that adds some stability to the outside portion of the knee is the anterior lateral ligament reconstruction. And this procedure takes this graft right here, and we essentially stabilize it right here, proximal and posterior to the lateral epicondyle. And then we also stabilize it halfway between Gertie's tubercle and the fibular head, so right in here. And that can be done to recreate the ligament that typically tears when there is a Sagoon fracture. But again, it's important to look at the evidence. So there are multiple studies, one of which is a retrospective study of 54 athletes who underwent an ACL reconstruction compared to 53 who did an ACL reconstruction plus the ALL. And what they found is when they did this combined procedure, patients were more likely to have less rotational instability. Patients also were more likely to have more stability in the anterior, the front to back plane. So there was 2.5 millimeters of laxity in the ACL group, and there was 1.2 millimeters in the group that had an ACL and the ALO. And this was statistically significant. There is also another study that was recently presented at the ISACOS meeting in 2025, and patients were randomized to getting an ACL reconstruction with the gold standard, the BTB, or a hamstring ACL reconstruction with this extra procedure, the ALO. And what they found was that 42 patients experienced a graft failure, so 7.6%. However, only 4.2% of the patients in the hamstring group experienced graft failure compared to 11% in the BTB group. So the addition of this procedure leads to a 3%, like a 3 times reduction in the risk of injury. So in summary, it seems that both of these procedures, the LET and the ALL, are effective in minimizing the rotational instability and decreasing the risk of ACL failure. But like everything, we need more studies to make sure that over the long term, this is safe. This is all research and data that has been popping up over the past 10 to 15 years in an attempt to understand the best way to minimize ACL failures. And the last way that we can talk about is, again, everything goes back to the first slide. We said the goal of the ACL is to resist anterior translation and rotational forces. Unfortunately, some people, the way they are born, their knee is shaped in a way that makes it more likely for them to experience ACL tears. And one thing that we look at is the slope of the tibia, which is kind of outlined here. That is this shape right here. So if the goal of the ACL is to stop the tibia from going forward, which is this way, and the slope is shaped like this, the steeper the slope, the more this bone wants to go backwards and this bone wants to go forward. Versus if this was flat, there would be less of a likelihood of this bone going backwards and this bone going forwards. So patients who have a high tibial slope, which is greater than 12 degrees, like is depicted here, they may benefit from a procedure where we cut the bone to make it flatter. So the average is 7, which would probably be somewhere in this neighborhood. So most people's tibias aren't shaped like this; they're more flat. And when it's more flat, the bones are less likely to move in that way. So this is something that has been pretty new, but a lot of research has been done to see the benefit of cutting the bone to reduce the risk of ACL failure. This particular study looked at patients between 2016 and 2022. They were able to include 14 patients, and the average slope of the patients before surgery was 18.6% or 18.6 degrees, and they were able to correct this to a postoperative slope of 7.2. And they found when doing this, 70% of patients were able to return to sport, and many patients experienced improvements in their outcome measures and their ability to do things that they enjoyed. Um, so I was recently in a meeting last week, and all of the big name orthopedic sports surgeons are talking about how this is something that they're now considering doing for patients who have failed an ACL and whose bones are shaped in a way that makes them a little bit more likely to experience an ACL injury. So in summary, a slope reducing osteotomy can reduce the risk of ACL graft re-tear in patients with increased tibial slope. And we continue to get more studies that seemingly support this. All right. Thank you.
Thank you, Dr. Oladeji, for an excellent presentation. That will conclude week 7 of the RISE Institute in Rugby Research and Injury Prevention Group Summer Lecture Series. We'd like to give a big thank you to Dr. Oladeji for joining us today and everyone in the audience for attending. Thank you all for attending.